Hello, Marriage. How are you? Good afternoon.
Good afternoon.
Professor Marriage Kazandak from Yeditepe University. Thank you very much for joining us from Turkey.
It's my pleasure. Thank you very much for inviting.
Thank you. Today, actually, we have a very exciting topic and also very exciting discussion. I'm looking forward and then we are going to discuss that with Professor Jafarzadeh. Professor Jafarzadeh is also one of the famous scientists. He's at in the sabbatical in Canada at the moment. So he has got a lot of things about sensibility test, and he has got a lot of things about also the way of appraisal as well. So I asked him to speak about the methodology of appraisal, which I know you are also very familiar with that.
Yes. I'm looking forward to listen to appraisal.
Okay. Thank you very much for joining. I don't know Professor Logani and his colleagues are in or not, but if they are in, please turn on the video. We can have some introduction before others joining us. Please feel free to start your video, everybody. Yep, I think the first author now joining us and some of other authors of this very, very good journal, very good publication. Good afternoon. Okay, thank you very much. Hello, Professor Radmi, thank you very much. And Dr. Imran, thank you very much for joining us, all of you. So we are about to start in maybe 10 minutes. Each of the authors team, if you're with us, please just raise your hand or turn on your video. Then my colleague is going to, okay, thank you very much. All right. Hello, Professor Jafarzadeh as well, join us. Hello, how are you? Gondar, how are you? Okay, good. Please, Mrs. Sadeghi, please make Professor Jafarzadeh as the co-host so he's able to share, and also the authors.
क्या नाम से है?
Okay, Professor Jafarzadeh, I think you are co-host, and if you want to test your system and share your presentation with us, please go ahead and test it. The Indian endodontist, and also he's now the Dean of the Educational Committee of APEC. Professor Sanjay Migilani, please go ahead.
Hello, everyone. It is a pleasure to be here. Thank you, Dr. Nikufar. And on behalf of Education Committee, I welcome you all. We have, many veterans of APEC. Dr. Taun is there. I think he is one of the legends of APEC. And my close friend, Dr. Mehmet, and my dearest friend, Dr. Logani.
Yes, please. Thank you, Sanjay.
Work together, and it is such a pleasure to have you here, Dr. Logani.
Thank you.
All the best.
Recording in progress.
Thank you very much. Thank you very much, Sanjay, for the introduction. Barbara, how are you? How is everything in Istanbul?
It's very well. It's going well. How are you, Professor Nikufar? And I am very happy to be here to see all you again, all faces, my colleagues, my friends. And I know, and I am sure today this session will be a scientific show. And thank you very much for your effort, and thank you very much for all.
Okay, thank you very much indeed. So by the permission from our seniors, all of you, we are going to officially start our 10th APEC Online Journal Club, which is also the first online journal club of this new year. And I use this opportunity to say Happy New Year to all of you. So far, we have 10 online journal club. According to the feedback that I have received about that, it was a very successful event so far, because this is absolutely different approach to how we discuss science, because usually we have a lecturer that they give us a lecture, sometimes just 5 minutes for discussion. But this event is a bit different. It started actually by one of our colleagues who actually accepted to put him in a very hot chair for the first time. So we put him in a hot chair that we put Archana today and Professor Logani and his team in this hot chair. That is actually a hot bench, actually, I think, because we have a lot of authors today. So frankly speaking, I'm going to be very harsh. Usually Professor Ibrahim control me, but he cannot control me at all. So as the moderator, I always ask the appraiser to be very harsh to the authors, because the goal is to teach, to our young fellows how to read an article, how to critically appraise, and how to critically read an article and try to filterize the information based. And if an article is published in Journal of Endodontics or in Nature or in Science, it doesn't mean that everything there is the fact. And we need to discuss the details. We need to discuss the methodology. And there is actually a way how to critically appraise a publication. Today, we have Professor Hamid Jafarzadeh. Hamid is one of the very, very good fellow endodontist from Iran. He is in sabbatical time in Canada now. He is very famous about his work on evidence-based medicine, evidence-based dentistry, and also about how to appraise an article. So he gave us a lot of lecture during the last 20 years in Iranian Association of Endodontics about how to criticize an article. Coincidentally, he has got a device that evaluates the sensibility of pulp. And this is also very, very important because Professor Jafarzadeh is expert in how to appraise, and he's also expert how to evaluate pulp sensibility and also, as we used to say, pulp vitality. So we asked him to join us. I think this 5 a.m. in Toronto. Am I right, Hamid?
At 8 o'clock. Morning,
8 o'clock. Oh, so it's
yes.
not too bad, not too bad. Good, good. We asked him actually to give us 2 sessions, to give us some information, 2 sessions. One about, in general, how to appraise an article, and then he's going to appraise the article, which is led by Professor Logani, one of the legend of Indian Association of Endodontics. He's a real gentleman. I would say that he's a real gentleman. I have this opportunity to meet him twice in India, and I really enjoy accompanying with him. So before I ask Hamid to share his PowerPoint and start, I'm going to ask Professor Ajay Logani, my very close friend, to have some introduction before we go and ask Hamid to start. Ajay, please.
Yes, please, Professor Nicofor. Happy New Year to everybody. And we're very, very grateful for you to have considered our article to be dissected today, if I may say. And as you rightly said, that the dissection is going to be done for the betterment of everybody. We print an article, we do a study first and print an article to the best of our understanding on that particular topic. And once it is peer reviewed, that is, we understand that they are also agreeing to our thought process. But then there are different thought processes, and that is what I understand, Professor Nicofor, that you've got this platform to share that. So let us have a very, very constructive discussion, and let that discussion go ahead and improve the science of endodontics for our fellow colleagues. Thank you very much, Professor.
Thank you very much, Ajay. I know that you have a lot of experience in vital pulp treatment and in regenerative endodontics. So your knowledge and transferring your knowledge to all of us is very important in this session as well. And I really welcome to the author teams that kindly accept to be with us, which I know all of them or most of them are with us today. So do you want to introduce them to all the participants as well? Please go ahead.
Yes, please. Thank you. Thank you very much. I have my colleagues with me. You already introduced the first author for this article, Dr. Archana. She was a postgraduate resident with us. She did her 3 years MDS and successfully finished it last year. And now she's back to her parent state, which is the God's own country, Kerala. And I think Professor Nicofor has been to Kerala when Sanjay had invited him to India. And the other authors with me are 3 of my own colleagues, my own faculty colleagues, Dr. Amrita Chawla, Dr. Vijay, and Dr. Sidhartha are there with me, I think, in this panel. And they also are very, very excited to hear the comments from everybody and have a healthy discussion. Thank you very much,
Okay,
Professor.
thank you very much. So you have a very powerful team. So let's go and see what's going on. Hamid, the stage is yours.
Thank you so much. Let me have an introduction, Professor Nekufar. Okay, hello everyone. Thank you for having me. My name is Hamid Jafarzadeh, and as stated by Professor Nekufar, I'm a faculty member of the Department of Endodontics at Mashhad University of Medical Sciences in Iran, and have the position of visiting professor at the University of Toronto now. And I'm going to speaking to you today about critical appraisal of scientific articles, and specifically about an interesting article has been published in the Journal of Endodontics 2022. I want to extend my gratitude to Professor Nekufar for considering me as the appraiser of this article, which is actually in my field of interest. I also want to declare that I have no conflict of interest or disclosure on the study presented. Okay. I want to talk about critical appraisal and pulp sensibility test and the related article separately. In fact, I have two parts in this session: critical appraisal and scientific article. Okay, I share my desktop.
I mean, you need to open your PowerPoint, I believe. Yes, and then go. Yeah, fantastic. Great, we can see the PowerPoint now. Go ahead.
Thank you so much. The article today we discuss is response to pulp sensibility test after full pulpotomy in permanent mandibular teeth with symptomatic irreversible pulpitis, a retrospective data analysis, which has been published in one of the first issues of the Journal of Endodontics in 2022. Firstly, I want to focus on critical appraisal. Why critical appraisal and how? As an introduction, we know that even peer-reviewed articles can be done poorly, and that is why appraisal is an essential part or step in any evidence-based process.
Professor Javed, sorry to interrupt you. Some part of your slide cannot be seen because there is a box actually on the right side on your screen that I think you need to, yes, that one. I think you need to close that one. Yes, that's much better. Yes, much better.
Thank you. It's an essential step in any evidence-based process. There is a lot to take into account when reading an article, poor methodology or even outright fabrication and fraud. Learning to critically appraise articles can help you recognize the good from the less than good. And appraising is more than just finding if the article is well researched and well written or not. You want to determine if it's useful for what you need. Okay, one important aim about the critical appraisal is to help the research which would be run further. For example, in topic we may have some researchers.
I mean, I'm really sorry to interrupt. Again, there is a box, I think, in your screen that cover the slides on the top. Yes, you remove that. Okay, carry on.
Sorry for inconvenience. Critical appraisal help us to help further studies to be done better than the same study. And so in each part of the science, critical appraisal should not be ignored. Sorry, I think I have some technical issues. Okay.
You can see the screen very well. Carry.
Thank you. What about critical appraisal checklist or critical appraisal skill program, which abbreviated CASP? This is a program for critical appraisal of scientific articles in the field of medicine and dentistry. Some famous universities have categorized this program. For example, University of British Columbia has summarized it as separate files for each of the studies. For example, case control, cohort study, clinical prediction, diagnostic checklist, etc., RCT, randomized clinical trials, or systematic reviews. I have collected all of these and prepare a checklist for the next sessions of the APEC Journal Club. And if Professor Nekoufar be in agreement, I will share it with all of the audience and send to him.
Many thanks. Many thanks. That would be great.
You're welcome. You're welcome. I think it will be helpful for the next sessions. Checklist for critical appraisal of the articles in APEC Online Journal Club. In different parts, we have prepared some questions. Is the main study question or primary hypothesis clear and relevant to the field of endodontics? Does the study add anything new to the evidence in the field of endodontics and dental traumatology? Is the study design appropriate for the research questions? Did the methodology address important potential sources of bias? Were the results accurately and adequately presented? Does the discussion outline the shortcomings of the study? Did the authors accurately compare the results with previous studies? In conclusion, supported by the results of is the conclusion supported by the results of the study? And finally, are there any conflicts of interest? Some of this question is relevant to the article we will debate and discuss today.
Hamid, may I ask you to go back to the previous slide, because that is actually a very
Sure.
important part. I think this is very
Sure.
interesting for all of us, especially for the educational committee, for Sanjay and Professor Abu Tahun and others. If we look at these questions, thank you very much. Hamid actually proposed such a things for our future appraisal, because so far what we did in 9 previous sessions, we just do the appraisal in experimental way. But now we are going to make it very, I would say, make a flow chart for that, or a checklist for that. That is amazing. I think that is a new approach in the new year, that we give such a list to authors as well as to appraisers. So authors will know that what happened for them and what type of question that we are going to ask them. On the other hand, others also, the appraiser also know that the way that they should follow and how to critically appraise the any article. This is based on the previous checklist that Hamid showed that to us. I told you, Hamid is expert in this field. Amazing. Sanjay, what do you think? Maybe we can propose that as the official things for all the future plan.
Absolutely. You are right, Dr. Nekoufar. I think this will act as a template for us, and we should scrutinize all the papers on this template.
Very good. Very good. Thank you very much, Hamid. Is there any comment or anything from anybody so far?
Actually, we do a similar exercise with our graduate students in the fall semester, and use the checklists to do that. And we found out that there are many to say if the article has been published in journals which are lower impact, So maybe we can consider this as well when selecting the articles in the future.
Amit, Merich mentioned something. Please go ahead and discuss that.
Thank you for all supports. We will focus on some of these items during the critical appraisal of the article we discussed today. Okay?
Okay, thank you very much. So we practice this suggested checklist. Thank you very much.
Yes. I will be happy if any comments during the critical appraisal can be sent to me, and I will recheck all the items and prepare a better one and send it to Professor Nakufar. Thank you.
Thank you.
Okay. I want to start the second part of the introduction section, which is about sensibility and vitality test. As I stated, the first part was about critical appraisal itself, and now we want to discuss about the tests. We know the difference between sensibility test and vitality test. Briefly, I wanted to describe more here. Sensibility tests assess the innervation of the pulp, and vitality tests using pulse oximetry, laser Doppler flowmetry, or other methods of flowmetry, thermometry, spectrophotometry can help us to determine the true status of the vitality of the pulp. In which situations testing the pulp is indicated? Indicate this in traumatized teeth and in some of the confusing tests. I chose this case from the textbook of clinical periodontology and implant dentistry, which belongs to Professor Linde. Shows a gingival swelling and bone destruction around it. Pulp test shows that the tooth, the lateral, the right lateral incisor is vital, and so there is no need to endodontic treatment. And as you see, healing after debridement of pocket and antibiotic therapy can be seen. So in such cases, pulp sensibility test and pulp vitality test can be very helpful to us and affect our treatment plan. Even we can do pulp tests after endodontic regeneration procedures. We have one case report by Professor Mahmoud Turabinejad, which have done an endodontic regeneration and reported it as the positive response to the pulp test after, I think, 1 year. So in specific cases, we can use pulp tests for confirming the outcome of the treatment we have done. Okay, let's have a flashback to the title, Response to Pulp Sensibility Test After Full Pulpotomy in Permanent Mandibular Teeth with Symptomatic Irreversible Pulpitis, a Retrospective Data Analysis. Okay. As the first question, I want to ask the respect author, first author or corresponding author or anyone else, why did you decide to do this study? In fact, can you add something to the existing literature by performing this research?
All right, can I go ahead and answer that
yes,
question?
Yes, please, Professor
Thank
Logani.
you.
Thank you very much.
Thank you very much. You see, we've been, as a department, been working on pulpotomy for last 4 or 5 years, and we've been trying to work on a lot of aspects as far as pulpotomy is concerned in mature adult teeth. And we've started to understand that the understanding of the outcome measures as far as pulpotomy is concerned are still not very clear. We only have one article, if I quote it right, by Taha et al., which tells us about the outcome of full pulpotomy on the adult mature teeth. And they have only given as a radiographic outcome and clinical outcome. And that also as far as bare minimal. When I say bare minimal, I would say that they've given an overview on the outcome. And as I said previously, what we understand after doing pulpotomy is that what outcome criterias can I see for a success or failure of full pulpotomy in adult teeth. So if I may give you an example, our thought process was that if there is radiographic calcification occurring over 2 to 3 years after full pulpotomy, should I be taking that as a measure of success or failure? We've raised this question many times among our group, and we really do not have consensus. And we're trying to get data on that aspect also. So just to cut it short, this attempt also has been to identify whether a pulp sensibility test, and if which pulp sensibility test can be used as a predictor for the outcome of full pulpotomy. I think if I can get the message across, I would be happy, please.
Yep, that's great. That's great. Is there any question about this explanation that Professor Logani mentioned? Is there anybody have any question? Please go ahead, turn on your microphone and ask your question. Professor Baber, it seems you have a question.
No, not question. Maybe it can be accepted as a survival if there's classification rather than failure, I think. Maybe it can be also accepted survival after full pulpotomy in irreversible pulpitis cases. That can be another point of view, maybe.
Okay, so you mean we should distinguish between success and survival?
Survival, yeah.
Okay, what do you think, Ajay, about this comment?
Sir,
maybe rather than failure, maybe not can be termed as failure if we have a classification inside the pulp chamber, root canal. It can be also termed as failure, survival, success or survival. I don't like to use the term failure in such cases.
If I get it right, Professor Nikofer, Professor is talking about calcification in the canal.
Yeah.
Yes. So the question is, one of the big problems for pulpotomy and the outcome of pulpotomy, if we have metamorphosis, calcification inside the root canal system, then obviously it is very difficult to get any response from pulp testing. So because you already mentioned that you want actually to use this pulp sensibility test, any type of that, as one of the measurements for the outcome, and this is the answer to the question that Professor Jafarzadeh mentioned. Professor Kayan said that even if we have calcific metamorphosis and negative response from pulp sensibility test, we still may call it survival of the tooth rather than failure. What do you think?
Okay, this is agreeable. I was just trying to highlight that these are two separate indicators for outcome. So I am asking that, so my point of view is that pulp sensibility testing, the results of that is one indicator for outcome, and the pulp chamber or the canal calcification is another indicator. And I agree with the professor that let us call that a survival in case there is calcification in the roots. That's what I understand from the discussion. The point which I wanted to highlight about the calcification is that when does pulp deposit secondary dentine is when we understand it is stressed. So these are two schools of thoughts. So try and understand the school of thought which I was trying to get. It's not related to this paper, but since we've started a discussion, we trying to say we want to see that after pulpotomy, full pulpotomy with MTA or biodentine in adult teeth, in case there is pulp canal calcification, what should I interpret that as? Should I interpret that my pulpotomy has been successful or the pulp has undergone dystrophic calcification? So that is the point which Professor brought in. He said, don't consider it either, just consider it as survival. So I would agree again with it in the hindsight. Yes. So I don't think so we require any discussion.
Is there any question or any comments?
Sorry.
Okay, Professor Kazandak, please. Yes, please. Professor Kazandak, you go ahead, and then we are going to have another comment.
Thank you very much for the explanation from the author, because I was about to ask that, because usually at the very last sentence of the introduction part, there is supposed to be a clear question to be answered at the end of the article. However, here it is said that the purpose of this article is to document and analyze the results of the Pulp tests, something like that. I think this is one point to appraise this article.
Okay.
Thank you.
Okay, good. Any other question? Any other comments? Yes, please go ahead.
May I add a point here, Dr.
Yes,
Nekufar?
Yes, yes.
In the next slides, we have some debate about the effect of the material used during apexogenesis or during vital part therapy on the outcome and the result of sensibility tests. Okay?
Yeah, sure, please.
Thank you. Okay, we want to start from the title of the article. Dr. Ajay, why you chose this title? Why didn't you use the cohort in the title? You know, it looks like a cohort study, a retrospective cohort study. And if you choose a better title, you had more visibility, more citation, blah, 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 blah. Why didn't you use the cohort in the title?
It's nothing specific for a reason for us skipping this word. We have done the word, we've used a data analysis out here. So we personally thought as a group that once we've used the word data analysis and used it with the word retrospective, that would be sufficient. But your point of view of having used cohort and having a better citation is well taken, please. We would keep that in mind. We would not be having any defense on that part. A cohort would
because if you mention cohort, then it creates it as a higher level of evidence. When you have a retrospective cohort longitudinal study, then other people, it may attract more attention. You have very good point, Hamid. Thank you.
It will be a more attractive title for the article for the readers to know the kind of the study, cohort study, not only analysis.
Yeah, could we use the word cohort with a retrospective data? Could we do that? And usually we've been talking about it as a prospective data when we end up using the word cohort. So Professor, Hamid, could we use it with a retrospective data, a cohort word?
Yes, yes, we can change the title to the, at the end of the sentence, a retrospective cohort study or 1 year retrospective cohort study. I think it will be more attractive for the readers of the journal and increase your visibility and further citations.
Thank you.
Professor Logani, I believe cohort studies are two types, retrospective and prospective. Both of them are longitudinal studies. Obviously, one of them is retrospective. When you go back to the data, like the one that you did, data analysis, or prospective. Obviously, the prospective one has higher level of evidence comparing to retrospective. That's the only thing.
Please,
Okay, I think there is another question from Professor Kazandak. Merich, please go ahead if you have another question because you raised your hand.
No, I forgot it. Thank you. I got my hand up.
Okay, Hamid, please go ahead. Hamid, we still have your that box that cover your slide on top of your slide.
Is it okay?
No worries, carry on. I think there is a window there that we can see that just a dark window. Doesn't matter.
Okay.
Okay, go.
Sorry for my preciosity, but I have tried to add everything I can to the article, from the title, from the abstract, choosing keywords, critical appraisal of the methods and materials, and all aspects of the scientific writing. Okay.
We appreciate that. We appreciate that. That is the goal of this discussion. That is the goal.
Thank you. Thank you. As we know, a part recently in the recent years have been added to the articles published by the Journal of Endodontics is the significance part in the first page of each article. I have added an screenshot from your article, Dr. Ajay. This is, I think, this is your conclusion, not the significance of your study. Are you in agreement with me?
You see, when we talk about significance, we understand they're looking at asking us the clinical significance. That's how I interpret their, as you rightly said, this particular trend has started over a couple of years with JOE. When they ask us for significance, we understand that they're looking at letting the viewers know in the end, in 3 or 4 lines, that what is the clinical significance of the work which you've done. And that is how we interpret this particular strata of the article. And that's the reason we put that we, based on the results of our study, as far as clinical significance is concerned, when you've done full pulpotomy, electric pulp test is something which would give you a much more reliable result as compared to the other pulp sensibility test. That is how we have interpreted this, Professor Hamid. Thank you.
Thank you for your reply.
Thank you.
Okay, and the next part about the keywords. I checked all the keywords you chose: cold test, electric pulp test, full pulpotomy, mineral trioxide aggregate, and pulp sensibility test. Yeah. Only MTA or mineral trioxide aggregate is present in the mesh list. I searched some other keywords, other candidate keywords and found dental pulp tests, pulpitis, pulpotomy, endodontics, sensitivity, specificity, and predictive value. All of these are included in the mesh list. I think you can choose better keywords for such a study. And again, I should say that with better keywords, you will gain more visibility, more citation, and blah, blah, blah.
Okay. Thank you very much.
Today, Professor Logani, I think today, Professor Jafarzadeh is going to be very popular for all of us because whoever is going to publish anything in the future may consult with him before we submit it. Amazing.
Yes, and you see, I think my first author, Dr. Archana, should update us. She did search for all the mesh words, and these were the ones which she saw. As far as sensitivity, specificity, and predictive value, we were not really looking at taking them out, so we may not have used it. As far as pulpotomy is concerned, it's a mesh term, but since we needed to differentiate here between partial, deep, And the other pulpotomies, we used the word full pulpotomy, but to your point again, if we would have used just pulpotomy, we would have ended up better a mesh term. Dental
The
pulp.
mesh, sorry, in the mesh list, we have only pulpotomy terminology, not full pulpotomy or partial pulpotomy. Only pulpotomy is present in the mesh terms list.
Okay.
Thank you.
What is the point that we have to just follow the mesh terms, or can we add up anything to that?
This is optional in most of the journals, but if you choose the terms included in the mesh list, certainly you will have more visibility. Articles you have prepared have more visibility, more citations, etc.
But the problem is mesh terms, to my understanding, mesh terms is very general. As Professor Logani mentioned, for example, when we want to go ahead and speak specifically about the type of pulpotomy, we cannot find anything. Or dental pulp test. Dental pulp test is very general, not very good for endodontics.
We can use dental pulp tests, replacing cold test or electric pulp test, and the meaning is the same.
Okay, understand.
But included in the mesh list.
Okay, thank you very much. So let us have a 2 or 3 minutes break by watching one of the video from our sponsor. Zohra, please go ahead. Okay, thank you very much all. Let's go back to what we did so far. So far, we actually Hamid suggests something about the title and the keyword, and Professor Logani explained about that very well. Thank you very much, all of you. Hamid, please share your PowerPoint again. While you are sharing, I'm going to ask Professor Ibrahim to give us some comments so far. Professor Abutan, what do you think so far? Okay, please unmute yourself. Professor Ibrahim, yes.
Yeah, thank you, Professor Mohammed. First of all, I want to thank you for the new look of the webinars. It's really great. And with such great names, such
Thank you.
like Professor Hamid and Professor Logani.
Thank you.
Really
Thank you so much.
the discussion. My opinion, you know it, Mohammed, because I think we used to say in Arabic, all the roads lead to Rome, whether we use this or that. For me, most important is the results of the conclusions and the results of the study. You know, we have always non-believers, even in dentistry. And this issue usually divides endodontists. We are divided, especially when we are going to define between doing a pulp cap or going to pulpotomy. This is a huge issue and even in endodontics. Dr. Rikuchi, he criticized even the ASE, you know, statement on vital pulp therapy because it neglects histologic, you know, facts. So we always, these differences are present. I'm enjoying, I'm learning a lot from Dr. Hamid, and hopefully in our next papers or our next discussions, we'll be aware of all the hints we need today. But I think this article will give answers, and it will be added to the increased volume of literature on this issue. Every day we have colleagues in the Facebook pages who are seeking our advice, our opinion about vital pulp therapy, pulpotomies, if they work, and unfortunately, we can see childish answers. No, don't do this, don't do that, it is not successful. But this is a very clear answer to all those who ask their colleagues not to do vital pulp therapy. Mohammed. This is what counts at the end for me, whether we call it sensibility or we call it vitality. You remember about Dr. Hamid mentioned the paper, the great paper, 2011 with Dr. Turabinijad, which was the first study on its kind on replanted tooth, and the tooth was responsive after 5.5 months. And his answer was clear, even if no pulp exists in the root canal, but the tooth was responsive. And this is a very good answer to those who do not believe on the, let's say, endodontic of the future, or the future of endodontics. This is my opinion till now. I will conclude as usual at the end, but I think this is a great discussion. Thank you, Professor Mohammed. Thank you for the new look. Really, I like it very much. Thank you very much to all of you.
Thank you very much. And I think Professor Jafarzadeh is going actually to also appraise this part. So we leave it to Hamid to carry on. Hamid, please go ahead.
Thank you. Let's go to the next slide. Okay. Okay, I want to start the introduction section and emphasize important parts of this section, including the definition of the full pulpotomy and how to assess the outcome, what's the difference between the clinical outcome and the radiographic outcome, what's the difference between AAE statement and ESE, European Society assessment, and finally, what's the aim of this study? As the respect authors stated, the full pulpotomy has been attempted in mature permanent teeth with success rate of 75 to 95. The outcome of this kind of treatment can be assessed clinically, radiographically, or both together. Clinical success can be evaluated by the symptoms of the patients, including spontaneous pain, tenderness to the percussion or palpation, and any other pain the patient may present. And the radiographic outcome is based on different systems, for example, pi or CBCT pi, etc. The authors have used the pi system in this article. Okay. 120 patients included in the study. The age was between 16 and 35. The exclusion and inclusion criteria have not been defined precisely, which I will discuss about it in the next slides. In the first visit, a positive response to cold and EPT was seen, and a radiograph pi score of 2 was recorded. A single visit treatment using white MTA for full pulpotomy procedure under local anesthesia and rubber dam isolation have been used, and a standard methodology were used for all the procedure. As the authors have stated in the title of the article, this is the retrospective analysis and not prospective analysis, and all the patients have received the treatments before the initiation of the treatment. For pulp sensibility testing, two tests were used, cold test and electric pulp test using vitality scanner. And the follow-up period was 12 months. An important point about the article, the research is categorization of the response. They have used a response or no response. May I ask Dr. Ajay why they have used this classification for the response of the patients?
Yes, thank you very much for that question, please. You see, as far as cold test is concerned, we can only have a yes or a no response, that yes, the patient is responding, or no. As far as the electric pulp test is concerned, there are thought process where the numerical value, depending on which electric pulp test equipment you've been using, if it's the Parkwell or the one which we have from the Kerr, they have a numerical value from 0 to 80. So some of the school process, that some of the people think that, or they say that the numerical value to which the patient is responding at has some value to the correlation with the inflammation in the pulp. But to the best of our understanding, and the literature tells us that the numerical value of the electric pulp test does not have any corresponding correlation with the inflammation or the histological changes in the pulp. So for all practical purposes, it's either, so to give you an example, if a patient responds at a numerical value of 10 or a numerical value of 40, it is the same thing. He is responding. So we would record that as a yes response, even if to go to the extent that if he responds at a numerical value of 60, if he does respond, we do not take it as a delayed or an early response. We just take it as a yes or no. Now that's our thought process based on our understanding of the literature, please. Thank you.
Thank you so much for your reply. I'm completely in agreement with your classification, but as some of other articles have used different classification, I ask you this question. I agree with this classification completely. Thank you.
I think draw some comments and some questions. If all of us remember that in our previous sessions, we have a fantastic presenter, fantastic appraiser, Burçin. She is with us now from Bahçeşehir University from Turkey. And Burçin is going to give us some comment and some question. Ajay, be ready. Okay, Burçin, go ahead.
It's good to see you all again. Actually, my question was again with this categorization about response or no response. For me, at the discussion part, I saw that the author said that the threshold level, they are not talking about threshold level. For me, as an initial appointment, they give no threshold. So there may be an early response or late response. So is it possible the effect of this threshold on our outcomes? Because if the patient has an early response in the initial appointment, I mean, if they have, for example, 10 from 8, and the last session, if he has 80, it means there's a huge range between the first initial and the last first initial appointment and the last appointment. This huge range may affect our outcomes, and also vice versa. If there is a highest levels in the first appointment, for example, if the patient has 80 in the first appointment, and after a 1-year recall, maybe there is still a vital tissue inside, but it's more than 80, so it gives a negative to the electric pulp testing. So maybe it would be more reasonable to use these threshold levels. What do you think about it?
Madam, thank you very much. We are the basis of why we took no threshold levels has already been spoken about by me, and your point of view is absolutely right. The examples which you have given are also absolutely right. that if in a preoperative condition, if a patient is responding at a numerical or a threshold value of say 15 or 20, and after having done pulpotomy, it goes on to respond at 60. Should I take this? Should I be interpreting in between anything? Our point of view, madam, was that we should not be interpreting anything. So even if it was at 15 initially preoperatively, even if it gives me at 60 post-operatively at 1 year, it is a yes for us. So it was a vital pulp when we started, which is a prerequisite for full pulpotomy. And when I am following it at 1 year or 2 years, even if I am getting it at 60, there is still vital pulp. Your last scenario, madam, which was quite understandable thing, saying that if I do not get a EPT response at my follow-up at 1 year, and when I open the tooth, hypothetically, there may be a vital pulp present. In these cases, what Professor initially said, we would rely on our radiographic and clinical criteria. Okay. So what we are trying to emphasize is that the outcome of pulpotomy should be a combination of clinical, radiographic, and pulp sensibility test response. So even if you do get a pulp sensibility test response as negative at the follow-up period, but if you do not have any radiographic changes in the furcation or at the periapical, and if the patient is asymptomatic, I would still consider the success for pulpotomy, madam. I hope I've been able to get, you see, online is a place where it's very, very difficult to get across points. I hope we've been trying to get the points across, madam. Thank you.
Oh, you did a great job, Ajay. You did a great job. You are a very good professor. So you transfer your knowledge very clear. Thank you.
Thank you.
The only thing is when we say a response or no response, is it just for the cold test or for other tests as well? Do you use that for electrical test or just for the cold test?
Is it for me, sir, the question?
Yes, Ajay. My question is, when you say a response or no response, it is just for cold test. Am I right?
It's both that is for both the test. Yes, it's for both the test. Yeah.
Okay then. Okay, and Archana, please go ahead. I think you have a comment.
I wanted to add one point that based on the threshold level, when we talk about the threshold, we cannot consider the preoperative threshold and postoperative, because obviously after pulpotomy, the previous studies have also stated that the threshold level will be high. The tooth will be responding at a higher threshold response of EPT. So while considering based on the threshold level, it will not be reliable. And a response and no response will be more appropriate terms to use in case of EPTs.
Okay, Professor Jafarzadeh, is there any other question? Please go ahead. If
may I ask another question?
Yes, please.
Dr. Ajay, can or others, I don't know their names, can you propose an alternative for masking the effect of threshold? For example, I want to help. For example, choosing vitality tests rather than sensibility tests.
Yes, obviously, vitality test would be higher on the hierarchy for us to know the real status of the pulp after pulpotomy. But we do understand the problems, the clinical problems at present of applying pulp vitality test in traumatized teeth, as well as for monitoring the pulp vitality in other teeth, the problems which are associated with it. But your point of view, would pulp vitality testing be a better option? Definitely yes, please.
In most of the vitality tests, including pulse oximetry and laser Doppler flowmetry, we need a live tissue in the pulp chamber. And when we have performed a full pulpotomy,
May not be possible.
The possibility of gaining the positive response is very, very low.
Okay. All right. So maybe then pulp sensibility test is what we stick with.
And I think still this question can be extended even to electrical tester, because if we don't have live tissue inside the pulp chamber, what is the histology and how is the mechanism of the electrical conductivity to give us the response, Ajay?
Professor Nekofer, we've explained that very well in our discussion. And when we do come to the discussion, I think Archana would highlight that point of view. We've defended both for cold test and EPT well for the paper, please.
Great. We leave it to the discussion part.
Yes, please.
Okay. Another point, the researchers have used the vitality scanner, EPT. It has two probes, I think. One small probe for performing electric pulp testing in the furcation area. It can help you in performing the tests in mandibular molars in full pulpotomized teeth, I think.
Yeah, I think we've used a smaller, you are right, there are two probes.
Two probes.
Posterior and one for the anterior. We've used the posterior probe for it. I am not too sure on the probe, which I can use it specifically to test it at the furcal area. But Archana, anything on this from your side, please? Maybe.
Yeah, Archana, please go ahead. Please go ahead. Archana, turn on your microphone. Yes, please.
No, sir, I haven't come across the furcation probe, but the posterior one we have used that, sir.
Yes, that's what I said. It's the posterior probe which we've gone on to use.
Thank you.
Thank you.
Okay, the variables have been studied. Our demographic.
Hamid, sorry to interrupt. Burchin wants to have another comment. Burchin, please.
I would like to
Go
ask.
ahead.
I would like to ask if the authors applied the both tests at the same time, at the same day, electric pulp test and cold test at the same time.
Yes, we've done it at the same time, and we've also defended it. It's a very pertinent question because we really did not know which test to do, so we went on to the literature. So what the literature explains us is that the mechanism of excitation of the pulp tissue is different for both the tests, for the cold test as well as the EPT test. So they say that it really does not matter that which test is done before one. And as a matter of convenience only, we've done this test before the other one. And we've given a lag period of a couple of minutes before we conducted the second test, please. Again, our defense is there in the discussion, please, for the same point which has been raised by you, please, Professor.
Okay, thank you. Thank you so much.
Thank you.
Sorry, we have a slide in further. We have a debate in further slides about this topic for sequence of testing. Which one should be the first? Is there any difference between different sequences or not? We will debate about it. Okay.
Okay. Yes, please go ahead.
Thank you. Variables such as demographic profile, tooth, kind of tooth, quadrant, location of restoration, and outcome of MTA full pulpotomy, clinically or radiographically, were evaluated. Okay, I want to start appraise this section by debating about exclusion and inclusion criteria. Dr. Ajay, you have not focused on exclusive and inclusive criteria in the materials and methods section. In the results section and in the discussion section, we encounter some of the criteria, but I think it's better to have collection of all exclusion and inclusion criteria in the materials and methods section. What's your opinion?
Yes, the exclusion and inclusion criteria definitely have to be added in the material and methodology for any article. What we have to say for that is, since this was a retrospective data analysis and the data was taken from 2 or 3 trials which were being done in the department and they were extracted from them. So the inclusions and exclusions were already there for those trials. And maybe that is the reason why we did not put it as an exclusion criteria, because all the pulpotomy studies which are being done in the department have their predefined exclusion and inclusion criterias. And this data was taken from there. But your point of view that we should have included it in this, maybe, yes, we would agree to that, please. Thank you.
Yeah, at least the reason for full pulpotomy should be explained.
Yes.
Okay. All right. Yeah.
I mean, comparing to root canal treatment, why you decide to do full pulpotomy in comparison to root canal treatment.
All right. We would take that point, T. We'll take that point. I understand that. Okay. Thank you.
Dr. Ajay, maybe have the response to these 3 questions. Why this kind of tests? What about the reason of full pulpotomy? And this is status of tested population should be clearly described. If you can reply all these questions here is very nice. Thank you.
What is happening is the fonts are getting smudged. So what is the first question? It says why these kind of teeth? All right, why these kind of teeth? So it's just that mandibular molars, the first and the second mandibular molars, as we would all know, that they are the most prone teeth for caries. So the sample size being able to be there with us for the mandibular first and second molars is always higher than any other teeth for performing pulpotomy. The other reason why we prefer in our department to take the mandibular molars is because of the ease in taking radiographs and being able to see the furcation area as well as the periapical region area in mandibular teeth as compared to maxillary molars, where the anatomic noise may superimpose those areas and we may not have a standardized inclusion criteria because we've always been trying to take cases without apical periodontitis, that is PI score of less than 2. So that becomes a really difficult thing to do it for maxillary molars. And these are the 2 major reasons. One, the sample size coming in is more, since they're more prone, and trying to read them radiographically for the outcome is also simpler for the mandibular molars as compared to the maxillary molars, in our opinion. That's the reason why we've taken these kind of teeth. Why about full pulpotomy?
Sorry, Professor. I want to have a complementary question to this question. We know that irritability of different teeth may be different together, for example, because of different reasons, for example, volume of the pulp chamber, the extension of the pulp horns, and so the irritability of first molar, mandibular molar, may be different from the second mandibular molar.
Okay, all right.
Why did you choose both of these teeth?
Again, for a convenient sample size, we've not really looked at that aspect of, because this is a pooled data. So we've not looked at that aspect from your point of view, that the pulp chamber sizes may be different and the response may be different. Because of that, we've not taken that into consideration and we've not depended on that aspect, please.
You are right, but it seems that selecting both kind of tests can affect the results of the study, I think.
All right, so we could mention that as one of the limitations of the study.
Yeah, thank you. Okay. Thank you. And what about the reason of performing full pulpotomy for these patients?
So if you go by the understanding of change in pulp biology now, where we were looking at having the disease process occurring in toto, now in compartments. So that is where since 2013 and previously in India also, we had attempted full pulpotomy in such cases of irreversible pulpitis. And if you now understand that we are really looking at a paradigm shift as far as pulp biology is concerned. We really now understand Rikuchi's article, which was quoted in 2014, has clearly shown us that in spite of the places that you may have irreversible pulpitis diagnosis, there are chances that the radicular pulp may just be inflamed to the extent that if you give it as a conducive environment, you can save the pulp tissue. And so the cases where traditionally we would have ended up doing root canal therapy, now, not us, but globally the data is coming that we are attempting full pulpotomy. Now your question, why full pulpotomy and not partial pulpotomy? If that's the point which we are leading to, we've understood one, partial pulpotomy being a technically more difficult to perform as far as the excision of the pulp tissue is concerned. And the other thing, what we understand is that there is limited data to show us that if the success rate is equal. So we understand that full pulpotomy. So if you have three options for symptomatic irreversible pulpitis cases, should we be performing root canals now? We've understood that we can perform pulpotomy. Then the second question is full pulpotomy or partial pulpotomy. I've given you my reasons of understanding that partial pulpotomy may be a little more difficult to perform. And we really do not have data on the success rate of partial pulpotomy compared to full pulpotomy in irreversible pulpitis cases. And with the studies coming from demand about the histology, which is talking about deep caries and extremely deep caries and its histology related to pulp, we personally feel that it is safer to do a full pulpotomy in teeth with irreversible pulpitis. Please, thank you.
What about in comparison with root canal treatment? Which one
Yes,
you think is more predictable?
We do have a study from India in JOE 2017. It comes from Rohtak Dental College. And it has shown that published in JOE again, by the way, 2017, if I quote it right, please. It again goes on to tell us that full pulpotomy, as far as they've considered two things. One is the pain relief, and the other thing is the outcome. They have said that, and this is the only study, by the way, which has compared outcome of root canal with full pulpotomy in irreversible pulpitis cases. They said it's comparable, not statistically significant, and equivalent pain relief.
And
that.
what about the restorability issue? If the tooth is not restorable and it needs some sort of post-insertion or such a thing, or crown, do you still recommend pulpotomy? I think it was the question that Professor Abu Tahun also somehow mentioned.
Definitely, sir. These are cases, these are questions which have been raised from the time when we've been attempting regeneration in teeth. We cannot expect regeneration to be done in cases where we are really looking at having to put in a post or to do an extensive rehabilitation. So there, that becomes a relative contraindication for regeneration. In our opinion, those same relative contraindications would carry in for pulpotomy cases also, please.
All right. So the only things that we may say that in terms of case selection that has direct effect to choose root canal treatment or pulpotomy is restorability, and also PAI must be less than 2. Am I right?
Yes, perfectly well. And another study which has come out in the IEJ, where we've compared to see whether the effect of the cavity, whether proximal versus occlusal. So it's from the same authors, the same study in IEJ in 2021, where we did to compare whether the occlusal cavity versus a proximal cavity, did it have any impact on the outcome of full pulpotomy. Now that was also an interesting article, and we found out that actually no. But as far as tooth structure destruction is concerned, I'm sure we would not be able to perform full pulpotomy in those cases where you require extensive rehabilitation, Professor. Thank you.
Okay, thank you. Hamid, please.
Thank you. But when you use the full pulpotomy as the treatment of choice for such patients, I think the material you use for coronal restoration is very important. When you have matured roots and you chose the full pulpotomy, I think it's better to use amalgam restoration rather than using glasionomer or composite resins. What's your opinion?
A point of view, Professor Hamid, the same point of view we wrote to the International Endodontic Journal. Just give me a couple of minutes to explain. And we did discuss there that why didn't we not use amalgam restoration? And we said, we tried defending that amalgam restorations could also have been used. We did not. So we wanted to defend this point of view, the question which you have raised. So they gave an answer back, and we had defended by saying that, look, agreed, previous literature has told us that pulpotomy cases are better off when they are restored with amalgam. That is perfectly well documented in the literature, Professor Ahmed. But we had defended by saying that globally, because of the Minamata Convention with amalgam coming down, we really need to see and generate evidence with the currently available materials. And the currently available materials are resin-modified glass ionomer and bulk fills composites. So trying and doing evidence, generating an evidence with a material which may not later or sooner, not available with us, and trying and generate an evidence with the materials which will be with us was our thought process, Professor Hamid. Thank you.
Okay, thank you very much, Professor Başturk from Turkey. Fatima, please go ahead. Please unmute yourself and speak. Thank you. Go ahead.
Okay, thank you very much for this opportunity. Sorry, I had to miss the first part because I had a patient. But regarding of amalgam, I have a question. We know that amalgam is real that has to be condensed in order to settle on the cavity. But we know that for regenerative endodontic procedures, we use MTA. And we know that MTA can be fragile under the condensation pressure. And you didn't use, obviously, amalgam. But what's your opinion on that? If the MTA underneath amalgam breaks, then can it be of use?
Yeah, I think I would agree to your point of view, Professor Fatima, and we would agree to that. Professor Hamid has to also, maybe that point of view is also very well taken, that are we really looking at condensing amalgam over MTA, knowing the compressive strength of MTA. So
okay, Barbara, please go ahead.
Yeah. We have a study about the thickness of MTA over the pulp, and we found that you have to place at least 2 millimeters to 3 millimeters MTA to minimize the stress on pulp or something else which you put over to minimize the stress on it. Then with thick MTA, and after 24 hours, you can minimize the condensation pressure on the pulp or the tissue which you put on the material.
Thank you. And I know Fatima herself also did some studies about that. Fatima, what is your opinion about that yourself?
Yeah, the thing is, we did a flexural strength test upon MTA, and we know that we found that actually 2 millimeter thickness of MTA would break until the condensation pressure for amalgam, because the condensation pressure for amalgam is 9 megapascals. And if you have a thickness of 2 millimeters, then ProRoot MTA or Angelus MTA actually cannot withstand this much of a pressure. So wouldn't it be better if we put something on MTA if we want to put amalgam on it, so that would act as a buffer? Or wouldn't it be easier if we do not use amalgam? I personally do not like amalgam. I do not prefer amalgam, and it takes a lot of time and procedure to remove
we
amalgam.
should ask you to answer this question. What technique do you, because amalgam was your suggestion actually.
Well, actually, it was,
yeah, I think Dr. Jafarzadeh suggests
Yeah.
use of amalgam in this type of restoration, which I agree myself as well. But we need to put together all this opinion. Hamid, please.
Using a suitable base with high compressive strength in most of these cases may be necessary and resolve the problem.
Yep. Okay, I think the most important thing is when we want to choose pulpotomy, we need to choose the tooth that we can restore them with a simple technique rather than a complicated technique. So I think this is the best answer. But whatever you choose, that should be a very simple case. However, we are going to discuss other issues in the next slides and the future slides. Okay, Professor Jafarzadeh, please go ahead.
Thank you. Let's go to the next slide. Okay, you chose cold and electric pulp test. I asked you about the vitality test and no need to more describe about it. But why you chose only cold and APT? Why you didn't use heat test?
I mean,
Dr. Ajay.
yes, Professor Hamid, thank you very much. We
Thank you.
really do know that cold and EPT is the one which is the preferred one. Heat test one, controlling the heat, yes, you could do that, but it's lower in the hierarchy as far as the pulse sensibility tests are concerned for us. Cold, EPT, heat is usually, we at least teach our students that heat test is only done to mimic if the patient is preoperatively having sensation to heat. So to replicate his symptoms, to know the intensity, that's the only time I would want to do a heat test, considering the damage it can do to a white pulp, in spite of me having some controlled methods of delivering heat at present. Low in hierarchy, low in specificity and sensitivity as compared to these two tests. That's the only reason, please. Anything else?
Thank you. You are exactly right, and I wanted to only debate about it for the audience, but you are exactly right. Okay, thank you. And what about probe placement area? We have different studies that have indicated many parts of the tooth, including cervical area, middle area, coronal area, the tip of the cusps may be the best choice for the probe placement.
You see, if it is a preoperative thing, the best place is the mesiobuccal cusps inclines, as we do realize that that's the area where the highest concentration of the innervation of the pulp nerves is the mesiobuccal cusp inclines. So I think the
What do you think yourself, Professor? What do you think yourself?
You see, we've been, for us, please, I mean, let us be off records onto this. As far as EPT or cold test is concerned, I try and tell my students to put it right at the area of the cavity. So the place where it is exposed, maybe that's the area where but as I said, not any evidence based off record. That's where I would personally preoperatively love to put my EPT probe or my cold test in the area where there is cavity, maybe after having excavated and seeing if I can find a place where I can put my probe and do a cold test to really know the response of the tooth. Theoretically, I've already used the buccal cuspal inclines. Post-operatively, yes, please.
Sorry, perfect. What about the traumatized teeth? No need to excavation, and you want only to do the test.
Yes, for the traumatized teeth, if you are if it's a fractured tooth, we've usually been putting it between the cervical and the middle of the anterior. In traumatized, we would want to talk about anterior tooth more. So we really been putting it at the junction of the incisal and the middle third, again for the EPT in that area, and that is where I think it is recommended there, as far as the recommendation is concerned.
Okay, what about luxation injuries?
We've been doing it the same area, the middle as the, yes, please. I don't think so. I have not come across anything from your side, Professor Hamid, on this, your question, as far as the placement of the probe for luxation injuries or different type of injuries, please.
Most of the studies, not all of the studies, have proposed to use the middle area for placement of the probe on the buccal side of the teeth. We have a research by the University of Nigeria too, and we published it in Dental Traumatology, indicated that the middle third is the best place for performing the test, including electric pulse test, cold test, and heat test.
Not specific to any injury, like the query which you asked, luxation injury.
No. But I think all of the cases were luxations. I think no fractures were included.
Okay, thank you.
You're welcome. Okay, go to the next slide. Oh, an important point about the age of the patients. The patients included in the study aged 16 to 35 years old. And you have divided them into two groups. Why? I could not understand why you have divided this small range of the year into two groups. Can you explain it?
I think, Archana, would you explain this, please? I am not too clear on this point. The age I can tell you, but division of the two groups, Archana, anything on that, please?
Oh, yes, sir. Sir, to understand and to compare the age with the response of the pulse sensibility test to exactly know if there is any relation between the response to the age of the patients, we divided 16 to 35 with a 10-year age range, so that we can keep 16 to 25 in one group and 26 to 35 in one group. And when we take out our results in the terms of two age groups, and we considered the 26 to 35 as a slightly older age group, the cold test responses were more 10 cases responded in 26 to 35. And previous one study has also shown that like 21 to 50 years had more cold test responses in that, more accurate cold test responses. So we put a 10-year age range.
Any defense for that, which we've written in the discussion, Archana? That in that, if you consider that 26 to 35 more cold test, any defense in the discussion, please?
Sir, particularly in younger age group, there will be more apprehensive patients, or like anxiety can roll out the result, the response to the cold test. Also, in younger age group, the pulpal innervation will be less, and the pulp chambers will be more. The volume of the pulp chamber will be more. So in 26 to 35 year age group, we found out that the cold test response were higher than the comparatively younger age group. But actually 16 to 35 years is a small range, but to be more specific, we tried to find out if there is any significant difference. So we put a 10-year age group. 10-year age range between this group?
Sorry, but I'm not satisfied with your reply. I cannot understand the difference between two ranges, 16 to 25 and 26 to 35. I think there is no difference between them.
Okay. Just to add, so I had to refresh my memory for that answer. So Professor Hamid, 16 to 35. First question, why 16 to 35? Now, again, we do realize that age has no correlation with the outcome of pulpotomy. I think that has already been documented, but not to make that as a confounding factor. You see, when we're doing studies like this, where we are looking at studying an outcome of a particular or an effect of something on the outcome, we need to negate the confounding factors. So we try and see that, okay, we will try and take a certain age group and not the adult age groups, knowing that may not have an effect, but still it could be a confounding factor. So when we make a study design, the thought process is to minimize the confounding factors. So that's the reason between 16 to 35. Why did we divide it into two groups? This is just another way of trying and interpreting the data. So we have the raw data with us. And if suddenly somebody asks you a question, look, you have this data. Did the effect of EPT versus cold test varied with the age? So since we had a narrow age group, we divided it into two by a 10 years gap. Your point of view, very well taken, that look, 16 to 35 is one group, you still divide it, but it was just an offshoot, if I may use the word offshoot, of interpretation of the raw data, please. That's it. And
Thank you. But all of these patients are considered to be young patients. And I think if you have a wide range of the age in your patients, you can divide them. And the range of the age for your patient is not wide, I think. You could ignore this dividing and assessment of the relationship between the age and the outcome.
Sure, please.
This is my opinion. Okay, thank you.
This valued opinion, please.
Thank you.
Hamid, there is a question from Professor Arshad Hassan. So I asked Professor Arshad because he kindly typed it in the chat room, but I prefer actually to have that question by him. And Professor Arshad, this is a platform that we can make our network much better. So please introduce yourself and your affiliation, and then go on and give us your comment and questions. Thank you very much.
Good evening, everyone. I'm Professor Arshad Hassan from Pakistan. This is my first attendance of the Journal Club, and I must say I'm really happy to see such an excellent level of knowledge of exchange of knowledge. It's really excellent, and I'm really happy to join this group, this learned group of clinicians and researchers. I had two questions in the beginning at the time when you were discussing the methodology. Please correct me if I'm wrong. The initial time at which the EPT was done or the vitality was done was probably after the pulpotomy was done. So, probably the before pulpotomy was done. Am I correct?
Yeah. Yes, please. Yes, Professor Hassan. So two readings were taken, one before performing the pulpotomy and one after a year of performing the pulpotomy.
Okay.
Yes.
So my only concern was just a comment about the vitality readings, and probably the maybe you may not be able to compare the two readings or the level of the two readings, because before pulpotomy, of course, the pulp is the coronal pulp has pulp in it. The coronal area of the chamber has pulp in it, and you're testing the pulp vitality. And of course, now you've taken the pulp out, and you're now testing the pulp 1 year after doing that procedure. So the volume of pulp has decreased. So probably the reading of the pulp, the vitality may actually be different. So this is one point. And so can you please?
Yes, Professor Hassan, your point is the answer to the question which was raised almost 25-30 minutes back into the discussion, that why the response was only taken as yes and no. We did not consider the readings for this very reason, the explanation which you have absolutely got it clear in your mind and spoken out. So that's the reason why we only consider it as a response or a no response, to negate those factors which you have been talking about. Perfect understanding, Professor, please.
Excellent. Thank you very much. So my next question is about the fact that if a tooth requires a crown, because as you're working in India, I think we share same demographics and the same kind of patient behavior, and patients really come to us at a very late stage when tooth have undergone a lot of destruction of the crown. And at the time when they come to us, it has already gone a lot of damage to the crown, and a lot of tooth tissue is already destroyed. So most of these teeth require extracorporeal restorations, indirect restorations in terms of a crown. So my question is, if at all a tooth requires an indirect restoration, is a pulpotomy, full pulpotomy, contraindicated?
Absolutely no. Absolutely no. If a full crown is required, pulpotomy is not contraindicated at all. Absolutely no, Professor Hassan. You can go ahead and do a full pulpotomy and give a very safe crown on top of it. The only thing which I was coming to it, you can't do an EPT or a cold test after that. So
I think this is a dilemma in the endodontic treatment procedures.
Okay.
Okay, thank you very much. So we have a comment from Fatima Bashturk and also from Dr. Zimet as well. So Fatima, please go ahead, give us your comment. And I ask Professor Zimet and also Professor Motawasselian to be ready for their comment. Fatima, please go ahead. Time is very short. Please make it very quick.
My question is about the age of the patient, actually, the thing that we discussed. I want to ask, in your clinical practice, do you have an age limit for the patient that you apply vital pulpotomy to? I mean, for example, if the patient is 45, do you not use it or go for a full root canal treatment, or
Any age limit, Ajay, please.
Sir, what we've understood is that as far as vital pulp therapy is concerned, we did one way back in 2010 on IPT, indirect pulp therapy. He's one of my colleagues now whose thesis was on IPT. And when we searched the literature, they gave a blanket answer that age has no bearing on the outcome of vital pulp therapy. So that's what my understanding about the literature is concerned. As far as my understanding about the clinical, practical experience is concerned, obviously the response of the pulp decreases with age. The best response of the pulp is achieved when you are in the age group of 16 to 35. And what has changed over years is the availability of materials. So we really did not have mineral trioxide or biodentine around 15 to 18 years back. And when IPT or BPT was being done at that stage, they were being done with different materials. So at that stage, they may have had a point of view that age may be making a difference. Now, I personally feel that with the better materials, a good case selection, age should not be a barrier. My personal experience. I really do not know whether everybody would agree on to that. My personal opinion, please.
Okay, Professor Philip Zimet, please introduce yourself and also give us your comment and questions.
Thanks, Professor. As a past president of APEC, this is an amazing development, something which I had not envisaged 20 years ago when I was president of APEC.
Thank you very much for joining us, because in two recent sessions, we saw you and it gave us a lot of energy. Thank you very much, Professor Zimet, for being with us.
That's a pleasure. The problem now is that how can we reproduce this, this article, because I'm told that Kerr or Cybron no longer manufactures the analytic electric pulp tester. So what is now going to be available to us to be able to reproduce a similar sort of article? We've got MTA, but no electric pulp tester.
So should I answer that question, Professor?
Yes, please.
Yes, please. Professor, thank you. What in India, at least in Asia, not in India, the Cybron Endo has been taken over by Kerr. So we're getting that pulp tester. And sir, your question, you can use any electric pulp tester, the Parkwell from the US company, which is an handheld electric pulp tester. It has almost the similar readings, if I am not wrong. Only the numerical readings go up to 100 in that. And it has 3 modes, the slow, the fast, and the medium mode for the Parkwell Apex electric pulp tester. So any electric pulp tester can be used to reproduce the results of this study, please. Not necessarily Kerr, Cybron, Endo. Thank you.
Is there any difference between the mechanism of how they work? I mean, the electrical pulp tester?
No. What we've tried going into that details also, Professor Nicofor, and as I rightly told you, the Parkwell, it has the only difference as concerned to the one which we used, has only 3 modes of delivery of, so it's the speed, it's the delivery of electric current. I really not sure. We had written it to the manufacturers also. So the numerical values go faster in the fast mode, in the medium mode a little slower, and in the slow mode a little slower. So the Parkwell has 3 modes of delivery. I think it's the electric current being delivered, and it goes up to 100, the numerical value. Out here, it goes to 80. That's the only difference. No significant difference as far as the mechanism is concerned, please.
Okay, and because of the time, usually we finish our sessions in 90 minutes, but today we still have 100 participants with us and listening to that. But I don't know, Hamid, how many slides do you still have?
14, I think.
Okay, so it seems
fast forward now. Fast
forward.
forward.
We may have another sessions if you like, because I have received a lot of questions that they want actually to know the mechanism, how the electrical pulp tester will work when we don't have any pulp tissue inside the pulp chamber. So before we go ahead, Ajay, we cannot wait until discussion. Can you answer this question? And then we go for extra time.
This answer is there in our discussion. And I would request Archana to speak on this. Archana, please, could you just
go ahead.
Immediately, short 30 seconds, tell how EPT could work even in cases where we do not have pulp tissue. One starting from, okay, Archana, could you please?
Yes, sir. Actually, in our studies, we have selected the electrode position into the midway between the cervical and middle third of the tooth, so that we position our tooth by circumventing the coronal restorations, the composite as well as GIC. So we know that MTA has a electrical conductivity, even though it is weak, electrical conductivity is present for MTA. So with that means even after removal of the coronal pulp tissue, the remaining vital pulp can respond to the electrical stimulation. So the basis of the electric pulp test is that we have to provide a stimulus which can overcome the resistance of the enamel and dentine. And so since the MTA is also having an electrical conductivity, we are presuming that the electric pulp tester, the electric current which we are providing is able to circumvent the restoration also.
Okay,
It's
still, I
complete-
think there are a lot of debate about that. We can discuss a lot about that, I believe.
Professor Nicofor, what she tried explaining is very well written in the discussion. It's been defended.
I know.
And it's been defended with the evidence. So I don't think so. The questions would raise on that. If they read it and go down to the referencing which we've given for it, we would say that composites, we do know our inert materials would not pass through. RMGIC is almost similar. So only the choice of positioning of the probe is required. And as she said, ultimately you're looking at overcoming the resistivity of enamel and dentine, which we presume is happening. Based on evidence, please.
Okay, thank you. Okay, Hamid, please carry on and try to make it a bit quicker if possible.
Sure, thank you. Okay, next slide. We can skip this slide about dropout and loss to follow-up because it's not completely relevant to this research. So I skip it. May I ask this question from one of the co-authors because I think Dr. Ajay had been tired for prolonged involvement in this discussion. I want to ask about the follow-up period. Is it sufficient? Is it sufficient or no?
I think there
1
are
year.
So anybody can be there. Sidhartha, would you want to answer that question, please? Dr. Sidhartha.
Thank you.
Thank you, sir. Yes, I will be answering this question. Sir, as per EAC, sir, the adequate follow-up is, they say the follow-up should be at 6 months, 12 months, and then yearly up to the 4 years. So the ideal follow-up is obviously 4 years, but we have taken 1 year, and that is also in most of the studies 1 year follow-up has been there.
I think when we have a periapical lesion and we do endodontic, orthograde endodontic treatment, 1 year may be considered as sufficient, but for vital pulp therapy by full pulpotomy, a longer period of time may be more relevant, I think.
Yes.
Yeah, thank you.
Thank you.
Okay, next slide. I skipped this and reached to the data analysis. The authors have used Pearson chi-square test, Fisher exact test, and McNemore test for comparison between pulp sensibility test and their association with the outcome of MTA full pulpotomy. Okay, some question here. What about the sample size? You have not discussed about it. And although this is a retrospective cohort study, but I think you should calculate the sample size and debate about the power of the study using the samples included, blah, blah, blah. Can you explain this for me? Thank you.
I do not know whether, Archana, the statistician's point of view for a retrospective study for a sample size, please.
Since we have been taken the cases from 3 completed trials and 1 ongoing trial, so totally 4 studies data were taken and 120 patients were the sample size of total. So the trials which we have been conducting is according to the sample size the statistician calculated. 120 sample size was the total sample size. So the lost and the patients which haven't completed 1 year follow-up were excluded. So we came down to the sample size of 96. And yes, sir, I agree to the point that we could have included the power of sample size in the study.
Okay. Okay, please. Thank you, Professor Amir.
Thank you. Let's go to the next slide. Studies about the tests in medical sciences. Most of them calculate sensitivity, specificity, positive predictive value, negative predictive value, precision, accuracy of the test. What about this research? Why didn't you calculate these items?
For me, to understand the sensitivity and specificity, what I understand is if you're looking at taking it out for a pulp sensibility test, we need to know the real status of the pulp. So that is only externable when we go down again.
Exactly.
So our histology. So it's not possible for us to do it in a pulpotomy case. For a pre-op, which one was more sensitive, specific? We could have done that by taking out the pulp from the coronal and subjecting it to visual as well as to histology, but we could not have known it post-operatively, please.
Thank you. Your answer is completely right, but I think you should debate about this in the discussion section, why you haven't calculated these items in such a study. Thank you.
Thank you.
And what about the results? The mean age was 25, 55% were male, and the higher number of teeth responded to EPT comparing the cold test. Some other items such as quadrant means left and right, the tooth means mandibular first or second molar, and the location of the restoration means proximal or occlusal placement have been considered and analyzed. The 1-year follow-up, only 6 tests were classified as failure, which means no response to the pulp tests. This is the main part of the results. And also we have one table and 3 charts for explaining the results. And as we should manage the time, I increase my speed, Dr. Nekufar. Is it okay?
Yeah,
Thank you. Thank you. We want to start the discussion section. In scientific writing, we have a structure for the discussion, which is the most important part of a scientific article. Paragraph 1 should include what did the study show and also address the aims stated in the introduction. You have stated the aims stated in the introduction, but you have not stated the results of your study. This is the first point. In the second paragraph of the discussion section, important point is here. You have stated 4 references for application of pulp tests in vital pulp therapy, but all of them are direct pulp caps or indirect pulp caps. So using these articles as the evidence for this kind of article about full pulpotomy seems to be irrelevant.
Surrogate referencing. Surrogate referencing, you're putting 2 plus 2. We do not have any articles for referencing as far as pulp vitality and full pulpotomies were concerned. So you try and take the closest situation. And the closest situation in vital pulp therapy is DPC or IPC. That's the only reason for quoting such articles. You rightly say that when you are looking at comparing your results, is not going to have any meaning, but surrogate reference.
Yeah. I love surrogate referencing. That is the best explanation. Thank
you. This difference should be described here. You are right, but I think it should be described here. Okay, thank you.
Ajay, you are a politician rather than a researcher. Perfect. You should be the president of India.
And another issue about the references, I want to ask Sarah. You have stated that despite, You have stated that despite the general belief about the result of pulpitis after full pulpotomy, 2 studies have indicated that they are applicable after full pulpotomy, but both of them are seems to be irrelevant. First of the first reference is the Simon's study. Should pulp chamber pulpotomy be seen as a permanent treatment? Some preliminary results.
Yes,
as you see in the highlighted area, this study has shown that using EPT for pulp testing after full pulpotomy is not beneficial for us. This is the first reference you use. And what about the second one? Treatment outcomes of 4 vital pulp therapies in mature molars by Askari et al. From Iran, which no assessment of the reliability of the pulses have been done in this article. So using each one of these references to confirm the results of your study seems not true. What's your opinion?
I would again go through it detailed. Simon is the article in the IEJ 2013, if I'm not wrong, and we've quoted it in our introduction also, and have said that he has done electric pulp testing, but we have come to the conclusion that it was on a limited sample size. If I am correct, it was on 16. Now that is what we've taken it as a lacunae, that he did do electric pulp testing in these teeth, but they were only limited, and because of the limited sample size, the results cannot be dependent on. That is why we went on to do on a larger sample size. The other one, there is another study.
But sorry, Simon has concluded that the result was ambiguous in most cases and was not considered a reliable technique for pulp sensibility assessment.
That's the reason which we have given in our article, Professor, that it was on a limited sample size. So the ambiguity could not be settled on a limited sample size. That is why we went ahead with almost 10 times the sample size. That's
and
the
Ajay,
reason.
I think the difference between your study and their study is the use of a very special probe for the posterior teeth, because you use very special narrow probe, as Hamid mentioned, that you use the one that we use usually for the focal area, which maybe that is the reason that you get the answer and they couldn't get the answer, if I want to be positive.
All right, please. Thank you for the defense, please.
Thank you.
I do not show, okay, please. Thank you.
No problem.
We
you can
go
continue.
ahead. I really do not know about, I would need to go through this. You say there is either Archana would answer this question or no assessment of reliability of past. I would check onto this, please. Your point of view. Yes.
Thank you so much.
Yes, Archana, anything you can put in fast, please?
So then, as the article, they compare the 4 different vital pulp therapy, and in that they have done electric pulp and cold test 1 week after the treatment. They haven't taken out any reliability or any relevance of this test. We have mentioned that they have done the test after 1 week of the procedure.
So you mean after 1 week that we couldn't get the answer, or maybe after a year that we can get the answer? Because when we put material in direct contact with the pulp tissue inside the root canal, still we are expecting to get the answer, because there is no regeneration or anything like that. When the pulp is vital inside the root canal, still we need to get the answer. So there is actually a confusion, I believe, as well.
Okay, we will check onto this, please. She's not been able to get the point across. What I understand, if I remember this article clearly, this article is not specifically on pulpotomy. It is on different vital pulp therapy procedures, which includes DPC, IPC, pulpotomy. And in the table, they have given that they've done the electric pulp test, but they have not divulged that for which type of pulp therapy was that answer for. But I would again check onto this, please.
You're right. You're right.
Thank you. Okay. The effect of material used in full pulpotomy. We can use the mineral trioxide aggregate, SEM, calcium hydroxide, zinc oxide, ogenol, biomaterials, for the purpose of full pulpotomy. Some of these materials are inductive and affect the pulp to be calcified and the chamber and root canal be obliterated. This is an important point you should discuss in the discussion section. You have used MTA and then you have tested the pulp. After 1 year, the probability of the calcification in the coronal area of the root canal is high, and so the probability of decreasing decreasing the results of the pulp test should be considered. What's your opinion about it? For example, in another view, if you use zinc oxide ogenol with no inductive effect, you may have no calcification and no obliteration of the canal, and so you may have more positive results after 1 year. What's your opinion?
It's food for thought for us now. It's dinner time for us, Professor Hamid, and you've given us a very good research question, whether my pulp sensibility test would work better when I do with MTA or zinc oxide eugenol. He's given me a research question. We'll
Okay.
Thank you.
Oh, yeah, done. Thank you very much. These discussions always.
Yeah, we had an amazing time. We had an amazing time. I should say that this is because of Professor Jafarzadeh, because in our all previous 9 sessions, we had a lot of good discussions, but this time it was wonderful, wonderful. And also this gentleman, Professor Logani from India, amazing, amazing. I think your students are very lucky to have you as the leader, for the research leader. I really enjoy from the session. I couldn't understand that we talked for 2 hours now. Hamid, do you want to go to some slides, and then I want to ask Professor Abu Tahon for the conclusion?
Yes, please.
Yes. We have discussed about the sequence of conducting pulp tests. I think we can skip this slide. Oh, very, very important point about the gold standard. Was there a comparison with an appropriate reference standard? This is an important question in such a study. And we know you had no gold standard. Is it right?
Yes, histology could have been only gold standard. If you had to compare, I've already answered, not possible. Sometimes you really have to live with this kind of answer and say, this is the best I can get out of my research. Unless until we go ahead and do it on an animal study, maybe then, yeah.
Yes, and we know that the best results in such studies obtained when you have a gold standard for comparing your results with this gold standard. And so I think
what is your suggestion, Hamid, as a gold standard in this type of studies? What is your suggestion?
For example, in some research, including one of mine, which has been published in 2021 in Australian Endodontic Journal, we included teeth which needs the full root canal treatment, and we compared the results of our study with the gold standard, which was the root canal treatment, and we could directly.
The thing is, in this study, they were looking for vitality or at least sensibility. So root canal treatment cannot be a good case of gold standard in comparison with that.
Yes, you're right.
I would say just natural teeth, healthy teeth, maybe we can compare.
It's not applicable in all kinds of researches. Dr. Nekufar.
Yeah, but in this research, maybe that can be compared with a natural, for example, lower mandibular teeth on the other side, if that one hasn't got any restoration or hasn't got any root canal treatment or pulpotomy. What do you think? Can we compare them with that as a control? Positive control?
Yeah, yes, it can be considered as a control, but not gold standard.
Not gold standard.
No. Gold standard has a different definition in such studies, and so it can only be considered as a control tooth.
Okay, thank you. I think there is a question from Merich. Merich, we are out of the time, but go ahead and quickly ask your question.
I think it can be root canal treated teeth can be used as a control, as a negative control. At least it shows that the operator does not take false negative from, let's say, gingiva. Thank you very
false
much.
negative is a good point as well. So comparison with false and positive control group can be another question from the authors of this fantastic article. Okay, Hamid, anything else?
No, thank you.
Okay.
Can I
Thank
continue?
you very much indeed. I don't have enough word to thank you all of you, and all of my colleagues that they join us today. We had actually 4 ex-presidents from Australia, from Jordan, from Turkey, from India with us. And it was great to have Professor Zimet with us, one of the pioneers of APEC. Thank you very much for being with us, Professor. That was great pleasure to have you all. Usually, Professor Sanjay just left us around 10 minutes ago because he has got something else to do. So usually at the end, we ask actually some of our senior participants to give us a conclusion, and also our appreciation to the authors team, to Professor Logani, and also to our appraiser. And today we had a very, very amazing appraiser as well. So I'm going to ask Professor Zimet first to give us a conclusion talk, and also after that, Professor Ibrahim Abu Tahun to close the session. Thank you very much from other APEC counselors, President of Iraqi Association of Endodontists, Professor Al-Hawaizi, and other colleagues from around the world. We have a great time. Professor Zimet, please go ahead.
Professor Nekufar, thank you very much. Professor Hamid and Professor Ajay, this was amazing. This was really, for someone that tries to submit articles to a journal. Now, I don't even know how you get articles published if with the effort and the information that you guys have put into this article. It surprised me that any articles ever accepted. So this was, if this is going to be the foundation for the future of how we look at the APEC Journal Club, this is really a wonderful next level. Professor Nekufar, you've taken it to another level through the efforts of Professor Hamid and Professor Ajay.
Thank you.
I look forward to the next journal and to the next meeting that we have. Thank you very much.
Thank you very much for being with us. Thank you, all of you. Okay, Professor Abu Tahun, the stage is yours.
Oh, thank you. Thank you. I want first to thank all the authors and all the guests today. And also I want to thank Dr. Zimet, our past president, our past audit, and also he is now honorary life member of APEC. We are really pleased and honored to have them with us today. And actually, for the second year now, we are continuing after we restructured the educational committee of APEC, we are following this path. The second and most important thing is for you, Dr. Mohammed, as usual, with a characteristic smile, you kill your guests and then you ask mercy for them. Thank you for this.
Professor Ajay, I didn't do anything. Today, Hamid did the job. I didn't.
Happy on my colleague.
My conclusion on all this study, I think that as a specialty, it is critical to understand where we need to be in the future. It's time to understand this, to take our endo practice out of empirism. This is very important to us because we know now that the statements about non-reversibility of pulpal inflammation should be reconsidered and should be revisited. Because irreversible pulpitis as a term is a misleading term. It does not reflect the actual state of the pulp. So we cannot rely on this. The pulp is a healing tissue. And I think if we compare the results of all these studies, hundreds of studies on this topic, we can understand the difference between the classical endodontic approach, which usually has either with epixification or other techniques, which has a zero response, compared to the response even in non-vital teeth, regeneration of non-vital teeth, what it reaches up to 34%. And so we can understand where we should be in the future. And this is the importance of such studies, which also give answers to many questions of our colleagues that unfortunately they are misguided by many good clinicians who work for different companies and do not give them the right answer on this question. Thank you very much for all of you. And of course, we always wait new surprises from Dr. Mohammed in future webinars. Thank you for all.
Thank you very much. Ajay, I want you to have some word.
No, it's. I think it's been enriching information shared from all the people, specifically Professor Nicofor, for your efforts for having done this. You see, getting everybody on a single platform during these COVID times, getting them out of their practice, everybody. So you've generated the interest. And Professor Hamid, I think you've really dissected our article for us. And we would be in touch in the future before we are sending any more articles.
It's an honor for me.
Yes, no, please, seriously, jokes apart on that. Really, this is how I think all my residents joined. And when we do have a journal club, this is exactly what we mean. Over the years, at least in here, we've lost that art of presenting a JC. You have reintroduced it to my residents. So I'm thankful for that, and a very safe year ahead for everybody, please.
Thank you very much, Professor Logani. Let me tell you something. Professor Hamid Jafarzadeh is actually affiliated to Mashhad University. Mashhad University is another city and somehow is our competitor to our university. But he's a very close friend of mine. And usually in all the conferences, when he has got some lecture, he is also very, I would say, gentleman, very similar to you, always very quiet, not like me. I am very naughty. Everybody knows me. I'm talking a lot, so I make a lot of noise around. But he is a very quiet person, very respectful. And I told him I should be your agent always because I need actually to advertise him. He's a true scientist, And I always learn from him. He's younger than me, but I always learn from him. And today it happens that we all learn from him. So I want to ask everybody to turn on their microphone, put their hand together for Professor Hamid Jafarzadeh Bakui. Thank you very much, Hamid, for your very nice appraisal.
Thank you. It's nice of you to say so. Thank you. Thank you.
And then I want to say that the author team did a great and brave job to accept our invitation we put them in a very difficult situation, but they accept that. Obviously, this article is very, very amazing. For the first time, they did actually an innovative approach in pulpotomy cases, and I am sure you are going to get a lot of citations in the future, and we are looking forward for the future work with you. And I know that you are working in the most prestigious Indian institute, and the ranking of your institute is the highest. I know that, and we are looking forward to work with each other. One of the goals of this session is networking, and I think today it happens. We introduced you guys to each other. We had good guests from Pakistan today, Professor Arshad Hassan. We had amazing people from around the world, from Australia to India to Canada, everywhere. That is amazing. Thank you very much. Also, we put our hand together now for the authors and the authorship group. Thank you very much indeed. Thanks. for accepting our invitation and being with us. And thank you very much, all of you, being with us. This session is live on the Facebook, and it's going out actually to be on the list of our journal clubs. So now you have access to all 10 online journal clubs, so you can see them, the recorded part as well. I will share them with you. Being with us in a month in our next journal club. Thank you very much all. We are ending up with the video from our sponsor. Thank you and goodbye.
A moment, Dr. Nikufar, a moment.
Yes, please go ahead.
Sorry, thank you. I want to apologize to the respected authors for this kind of critical approach. I know that it's easy to criticize, but not easy to run. I know it. So please accept my apology, Dr. Ajay and other respected authors. Thank you so much. Good luck.
Ajay, you should answer, obviously.
You see, I have a thing on my, if I can show you, I can't. I have written it in my room. I thrive on criticism. So criticism always gets the best out of you. So let's
Thank you so much.
take it constructively. And for our next paper, we would obviously take the inputs. Thank you very much.
And also
Thank
in
you,
the
it's your
chat room,
kindness.
there are a lot of thanks to authors, to Professor Jafarzadeh, to everybody. So please have a look to them. And if anybody wants to have any talk, please turn on your microphone. Professor Al-Hawezi, Professor Kazandak, others, Professor Shasia, Professor Ashraf, others. Anybody, if you want to have any word, please go ahead.
I
Okay,
would like to thank Dr. Hamid Jafarzadeh very much. The session, this is the highest level of journal clubs, I think, today by his
Thank you
means
so
and
much.
all of the contributors. Thank you really very much. And personally, I used to be a visiting professor at University of Toronto in 2008, like you. And since then, I'm doing critical appraisal like you.
Nice.
So I really congratulate, the level was very high.
Thank you so much for your kindness. Thank you.
Professor Al-Hawezi.
Well, this is another meeting that's so outstanding. I'm very happy being here with you. Really, we share ideas. We've got many ideas that are very close to this topic in Iraq with our PhD students. Maybe in a year or two, we'll be sharing the results. Thank you so much, Dr. Mohammed, and to all. Thank you.
Thank you and goodbye, everybody. Have a very nice evening, night, morning, or whatever you are in it. Thank you very much. Bye-bye, everybody.
Thank you.
Zohra, please go ahead. Thank you, everybody. Goodbye.
Good night, please. Permission to leave, please. Thank you.
Goodbye. Thank you very much indeed.
Thank you.